Good morning, everyone. I'm Noelle Spears. I'm the Vice Chair of Education for the Department of Pediatrics, and we are just thrilled to have everyone here today. This is our 4th annual Dina Hofkosh Pediatric Educator Symposium, and we are just so excited for all of the scholarship that we're going to share with everyone today. It was Dina's vision to really elevate and celebrate the work that we do in our department, and this really brings it to fruition and makes it so special to have everyone here today. We kick off our symposium with our Lee Bass lecture, and we have a wonderful lecturer and visiting professor today, Dr. David Turner, who we'll share a little bit about in a second, but first a little bit about Dr. Bass. For more than 40 years, Dr. Bass provided medical care to thousands of local children, and he really was a strong advocate for pediatric resident community-based medical education. He was a mentor to many students and really encouraged their work in the community as well. He also founded the Physician Alumni Association to build camaraderie among physicians. It's really an honor, and thank you to the Bass family and the foundation for sponsoring this lectureship. So Dr. Turner, Dr. David Turner is the Vice President for CBME at the American Board of Pediatrics and an adjunct professor in pediatric critical care at Duke Children's Hospital. He attended medical school and completed internship, residency, and a year as chief resident in pediatrics at Baylor and Texas Children's Hospital in Houston. He then completed fellowship in pediatric critical care at Boston Children's Hospital. He's published over 150 peer-reviewed articles and book chapters and presented at a wide range of national and international venues. He's held a number of local, regional, and national educational leadership roles before transitioning to his current role at the American Board. In his current role, he's committed to advancing innovation and helping lead a thoughtful transition, which we'll hear about today, to competency-based approaches to learning and assessment across the educational continuum. Please join me in welcoming Dr. Turner.
Morning, everyone. Thanks for that very nice introduction. And I just want to start by saying how honored I am to be a part of the Bass Lecture and all that that represents, and to be a part of this symposium today. I had the privilege of meeting Dina a few times, and she was a wonderful person. And it's great to see that she's honored in this way on an annual basis. So I'm privileged to be here and really appreciate the opportunity. So I'm going to spend the next few minutes talking about competency-based education. So as we get going, I don't have any disclosures other than I work full-time at the American Board of Pediatrics, and I'm also deeply committed to this work. So over the course of the next 45 minutes or so, there's a lot to cover. I'm going to briefly talk about the ABP, sort of who we are and what we do. That's mostly for the trainees in the room who might have not as much exposure to the American Board of Pediatrics yet. And then I'm going to talk about the alphabet soup of CBME, right? So there's a lot of alphabet letters in the competency-based education world. And I'm going to do some level setting because some of this may be new to some folks in the room, and talk about sort of what it means and what we're talking about when we talk about CBME. And then talk a little bit about some of the research that we've done over the last few years and where we're headed for the future as an overall specialty and really as a larger medical community. So first, the first couple of slides, sort of what is the ABP, sort of who are the ABP? We are the organization responsible for individual physician certification, right? So at the conclusion of training, when you become a pediatrician and you become board certified, our responsibility is sort of setting and maintaining standards of excellence with really an eye towards the lifelong learning process. And that's designed to achieve our vision, which is advancing the health of all children. So when we talk about competency-based education over the next hour or so, this is the lens that we use when we talk about advancing this work. It's really about how can we use the certification process to improve education, lifelong learning, and ultimately the care of children, right? And so that's first and foremost a priority for us as we're doing the work that we do. A large part of what we do is assessment, right? We're an assessment organization. We do assessment in general pediatrics and the 15 subspecialties that we primarily certify. And that involves a lot of assessments each year, right? We create over 50 annually. And one common source of confusion, right, is that there's this like small group of people sitting in an ivory tower writing questions for the boards. Absolutely not true, right? All of our content is created by all of you, right? So pediatrician and pediatric subspecialist volunteers create all of our content. Some of the volunteers are actually in the room today, and we very much appreciate that work. And what we see as our role is facilitating pediatricians and pediatric subspecialists to come together to define what it means to understand practice in your different content areas. And that's how we create our assessments. Other parts of what we do, sort of after you enter the door and become board certified, is continuing certification for the practicing pediatricians and subspecialists in the room. These will all be familiar to you. We do spend a lot of time thinking about how we can recognize the work that's already happening by pediatricians so that your work as a pediatrician or a pediatric subspecialist counts for your credit for the ABP. And we try to minimize this, like I'm also going to do this other thing for board certification. And that's an important strategic priority as we move forward. And then the final slide on this topic, we often get confused with other partner organizations. I've been at the board now for about 4 years, and I regularly still get asked by people that I'm pretty good friends with how my job at the academy is. And I have to clarify, what's the difference between the AAP and the ABP? So the AAP is our specialty society. They're responsible for advocacy, setting guidelines, and they have a quite important role now, probably more than ever, in advocating for the health of children. But we work very closely with them in a variety of ways. And then the ACGME, we see the ACGME as close partners, particularly as we think about the competency-based education work. And for those of you that are program leaders, thinking about your work and your role in sort of meeting the expectations of the ACGME and how you can do that through the lens of competency-based education and assessment, we'll touch on a little bit this morning and then over the course of the day. So what is CBME and what does it mean? So I'm going to transition now. I'm going to talk about sort of all of this alphabet soup of competency-based medical education. At its core, competency-based education is a patient-focused, learner-centered approach to education and assessment. So it often is defined as starting with the end in mind, right? So you decide what is it that the patients need from us, in this case, is pediatricians, and then you work backwards from there to say what should the priorities be to allow each learner to reach their fullest potential and really be able to achieve those outcomes. It doesn't feel like that should be rocket science, right? It seems like that should have been the plan all along. But if you think about how traditional education, and particularly medical education, has evolved, that's not always been the case, right? And so moving towards this world where the patient is front and center in the education and assessment program is really what CBME is all about. And when I talk about what I do with those that aren't in medicine, I get these blank stares because the public think we do this already, right? Because in the eyes of the public, right, parents, non-physicians, children, all the folks that are out there, when I talk about this, they're like, what do you mean this is a new concept, right? Which in that sort of reinforces what our obligation should be as a community to really advance this work and meet the expectations that our patients and their families have. So I'm going to get into this in a little bit more detail in just a second, but sort of at a high level, CBME is defined as 5 core components, and they're listed on the left side of the slide here. The first one is the outcomes framework, and those are the EPAs. And so some of you might be familiar with the EPAs. If you're not, I'm going to define that term in just a few minutes. And then there's a lot of work in the middle, right? So there's this education and curricular part of CBME. That's really important, and that happens locally in local context at the program level, and we're going to talk about that a little bit more. And then the final part is the part where we spend a lot of time thinking about is this idea of programmatic assessment. And what that really means is just sort of trying to get as many data points about an individual as you can from as many sources as possible to get the most clear picture of what they're ready to do. And so I'm going to come back to these core components in just a couple minutes, but none of this is really new, right? We've been talking about competency-based education for decades. The discussion in the graduate medical education space really started in earnest with the milestones, right? And so my guess is this is familiar to many folks in the room. There are many assessment forms that look like this, right? You have these behaviors, something like patient management, and you have these behavioral anchors that you're trying to decide where someone falls on a spectrum from novice towards expertise. And one of the questions that I regularly get asked is, well, aren't we doing competency-based education because we have these competencies and milestones, right? And so why do we need anything else? One of the reasons that we need something else is that if you think about the competencies, right, like the one I showed on the screen just a second ago, they're focused on individual behaviors, right? So there are these isolated tasks that you have to do in order to do something else, right? And so one of the problems is if you try to assess that in isolation, it's quite challenging, right? One of the things I hear from trainees all the time and also from faculty is when we're doing these milestone assessments, I don't know where to put someone, right? Because if I'm working in the emergency room and I'm working with a trainee and they're seeing a patient with bronchiolitis who has a little bit of oxygen desaturation, your decision in diagnostic reasoning may fall somewhere on a spectrum. But if you put them in another context, they may be somewhere else, right? And so trying to decide where the learner falls without the context of the patient can be quite challenging. And that's where EPAs come into play, right? So EPAs are patient-focused activities, right? So going back to thinking about sort of what the priority should be when we think about competency-based education, bringing the patients front and center, and they require integration of lots of these competencies sort of all together to do something that the patient needs, right? And so that's what we're trying to move towards, is a world where you're thinking about the activity that the patient needs as opposed to all the individual component part behaviors that contribute to that care. And so I've mentioned it a couple of times, right? So EPAs, here's the definition. In EduSpeak, they're entrustable professional activities. So that's a mouthful. It often leads to like a little bit of glazed over looks when I start talking about entrustable activities. I've been working on rebranding these for a few years now as everyday pediatrician activities. Resonates much better, and I think it really is a much more accurate reflection of what it is we're talking about, right? So the EPAs are the activities of practice. They're designed, they were developed by our community to represent the things that patients need for optimal care. And when you take a collection of EPAs all together, they can serve to define the expectations of a specialty, right? And so we've done that work as a community and really have defined who we are and what we do using the EPA framework. And as I mentioned on the previous slide, they require integration of multiple behaviors and competencies to do some activity. And another really key point is that they don't represent some new idea or sort of just another assessment tool. EPAs really define an outcome, right? So they define what it is we need to do as a pediatrician. How you assess that and the tools that you develop to make that decision is separate from the activity itself. And we'll get into that a little bit more detail maybe later today with the program leaders as we talk about sort of how to assess and how to make decisions about someone's readiness to do an activity. And so if you step away from medicine, and you say, okay, what are we really talking about here? Like, what is it as a concrete example that I can put my sort of wrap my head around? For those of you that are old enough to have had a teenager learn to drive a car, it's a stressful proposition. Having done it 3 times, I can attest. It's not the most exciting thing you'll do as a parent. There's a lot of stress involved. And there are a ton of things that you want your child to be able to do before they move into the driver's seat, right? Can they understand the steering wheel? Do they know the rules of the road? What do the turn signals do? Like, can I accelerate, decelerate? That's a big one. But the first time you get in the passenger seat, what are you really interested in, right? It's, can they safely drive the car, right? And so in EduSpeak, right, so the EPA in this case is, can you drive the car, right? That's the question of importance that really you as a parent care about as you're sort of working with your teenager. And all of those other things are important, this left side of this slide, but they're only important as a means to an end, right? So they only are relevant if they contribute to safely driving the car. If you think about how we assess in medical education, think about your own assessment programs, the trainees in the room, sort of what do your assessments look like? The vast majority of what we do in medical education is the left side of this slide, right? We talk a lot about the component parts. We spend a lot of energy saying, like, you know, what's your patient care milestone? What's your professionalism milestone? All of these things. But what we really are interested in are how those contribute to the larger activities, right? And so when you talk about competency-based education, it really flips the script, right? So instead of thinking left to right, moving right to left, right? So thinking about the end first and then working backwards to say, all right, you're not ready to safely drive the car. What's the reason for that, right? And so then once you figure out sort of what is the reason, then you can work on that topic or issue, and then you sort of move towards a more safer scenario when you're driving the car. And so switching back to the medicine aspect of this, like what are the EPAs for our specialty, we've developed as a community, and the board sort of partnered, as I mentioned earlier, right? We partnered with a group of volunteers from the community to do this work now more than a decade ago. To develop the framework. And so there were actually hot off the press, there are now 12 EPAs for general pediatrics instead of 17. And there's 7 for all the subs, and then there's some for each specific subspecialty. And just to give you a flavor of the kinds of things that fall into this category, these are some of the Gen Peds EPAs. One of them is about caring for the well newborn, right? That one is concrete. It's easy to think about. It's a very specific activity. And then some of them are much more broad, right? If you look at the next 2, this idea of managing common acute problems, that's a large portion of general pediatrics. And as you think about how that's assessed and how you decide if someone's ready to do it, there are a lot of smaller component parts that you have to think about, right? So some of the EPAs are relatively narrow. Some of them are more broad. But then if you take the collection of the 12 of them, they do a pretty nice job of compiling, like, these are the activities of the general pediatrician. Similarly, in the subspecialties, these are some of the things that are common to all the subs. And so for the subspecialists in the room, as you look at these, hopefully they resonate with you in terms of things that you are responsible for as a practicing subspecialty physician. And you will note that some of these are sort of very specific clinical activities, like providing a consult, doing a handover, leading a team. But if you look at the 4th one, right, this idea of leading in the subspecialty profession, that's an activity that's important for a subspecialist. But clearly, if you think about this in the training space, like, that's not an activity somebody's going to be ready for when they finish training, right? So the EPAs are designed to represent practice, right? And what you're doing in practice. And you may or may not be ready to do all of those things at the conclusion of training, depending on how the activity is defined, right? And so that's an important distinction in that we talk about the EPA framework in the context of graduate medical education, right? What are our residents and fellows doing as they're coming through? But they really are designed to represent the activities of practice. And you should be able to do most of those things when you're finishing training. So it's a little bit of a moot point most of the time. But some of the activities are designed further down the path, like that one as an example. And then in the subspecialty space, some of the specific activities are listed here. You can see most of these are also examples of very broad activities, right? I'm an ICU doctor, so I included the critical care, one of the critical care EPAs here, and the acute management of the critically ill patient, right? That's like 75% of critical care medicine, right? Rolled into a single activity. And so thinking about how that's broken into its component parts for both education, curricular development, and assessment is an important part of the competency-based education journey. And so one slide on a topic that really is a whole hour in and of itself is the idea that a competency-based framework can move us towards an equitable approach to assessment in a variety of ways. So there's a mountain of evidence that the current approach to how we assess learners across the entire continuum has a number of inequities, right? There are group differences in a variety of ways, most of which should be able to be avoided if we did our education and assessment process better. And so if there's intentionality in how a competency-based program is designed, it can really improve equity in the system for our learners as they're coming through. We also have elected to use our EPA framework to drive equity for the patients as well. So there's an EPA that we developed that you may have noticed on the previous slide that's focused on providing equitable care, which we feel is an important expectation for all pediatricians and pediatric subspecialists. And, you know, as I touched on earlier, making sure that both our learners and our patients are in a situation that is equitable is probably more important now than ever. And so if you don't remember much else from this talk, this is an important point, right? So the EPAs represent the foundation and the outcomes of our framework, but competency-based education is not equal to EPAs, right? So we often talk about them as synonyms, right? And there's this idea that if we change the words on a form, right? So we switch our assessment forms so that they're EPA-based instead of milestone-based, we in some way are doing competency-based education. You can make an argument that is an improvement, right? But there is much more to be done as we think about the competency-based education journey that goes beyond just EPAs. And so this gets us back to the core components that I touched on earlier. And I'm going to go through this slide. I'm going to walk around the circle in a clockwise fashion and just touch on each of the components and give some concrete examples of sort of what that means in practice. So far, like over the course of the few minutes since we've started, we've spent most of our time talking about the outcomes framework, right? And so the EPAs represent our outcomes. We have defined them as a community. And if you look at the competency-based journey across other specialties, right? So this is happening across specialties throughout medicine. I just came from a conference the last 2 days that ACGME and ABMS is the umbrella organization for all of the boards. They co-sponsor to bring groups together to talk about competence-based education, and every specialty had a team there. And we spent 2 days talking about sort of where we are on the developmental journey of competency-based education as a specialty and how we can continue to advance that work collectively. And one of the key foundational elements of that is defining your outcomes framework. And so that work for our community has largely been done. There are others that are in various stages of that in other specialties. But we have been a leader there, and I think a lot of folks are learning from our experience, which is great. But then really what we have to do is sort of translate those into action, right? And figure out how to use the framework to make sure our curricula and our assessment are designed to achieve those outcomes. And that's the part that's sometimes missing, and I'm going to touch on the data there in just a second. And so moving around to the right, so this idea of sequence progression really is the idea that you are logically developing learning experiences along the way so that they happen in a progressive manner for a learner. The pediatric example of this is, can you crawl before you can walk, before you can run? I certainly could do tales from ancient history from when I was a trainee, when I felt like not equipped to be in a situation I was tossed into right away, right? I was asked to run and I was like, oh boy, like I missed both the crawl and the walking lessons for this activity, and I'm going to have to figure it out as we go. And so thinking about that sequencing from a curricular point of view is an important priority, but it also is a challenge, right? Because there are a multitude of pressures that sort of lead to how curricula and the sequencing of rotations are developed, right? And so as a program leader, thinking about how to sort of deal with all those competing demands and make sure that the learners are getting the progressive experience that they need is a very real practical challenge, right? And so that's something to work through as you think about how to develop an approach that allows the learners to progressively move towards achieving the outcomes that we want them to achieve. Another part of that, right, other than the sequencing, is this idea of tailoring learning experiences, right? So making sure that the learning experiences match what the learner needs based on their individual starting point, right? So everybody, when they start a training program, starts at different points, right? You have different experiences from medical school, different strengths, different opportunities for improvement, and sort of understanding what those are as an individual, like in a self-assessment kind of way, is critically important. But then being in a position where you can share that with those that are educating you without feeling like you're going to be penalized or biased or seen as like the problem child is really important, right? And that learning environment and sort of the cultural element of this is a really important part of sort of thinking about how you can tailor the experiences. And then if you think about both general pediatrics and subspecialty training, there's a tremendous amount of flexibility built into the system now, right? And figuring out how to use that flexibility to maximally sort of prepare each individual to be their best self is really what competency-based education is all about. And then the other side of the learning experience coin is the teaching part, right? So the faculty also have to understand expectations and make sure that you're teaching the things that the learner needs to know. So here's where I use the example of myself not doing this very well, right? So as I mentioned earlier, by training, I'm an ICU doctor, right? So I've been a part of teaching residents in the ICU for many, many years. And I've done this wrong over and over and over again, right? Because what I usually teach the residents are the things that I find interesting, right? It's like ECMO, ventilators, like all the really cool things that I enjoy because I'm an ICU doctor. Those are not the things the general pediatric resident really needs to know from me as an ICU doctor, right? They need to understand sick, not sick, right? Like what are the early parts of a resuscitation, right? And there are activities, right? There are EPAs that we have defined that I, as an ICU doctor, can contribute to their learning in. But if you think about the way our learning in the subspecialty space especially works, right, it's usually focused on the things that the subspecialists really love, right? Because that's why they do what they do, and they're really excited about it, and they're trying to recruit every resident that comes through into their specialty, right? And that, don't get me wrong, like that's a part of what we're going to always do. But at the end of the day, when you think about the educational priorities for each of the experiences, they need to match to what the learner is trying to accomplish, right? And for using the general pediatrics example, right, making sure that the faculty understand, like, okay, like you can do your like fun and exciting things and you can really try to recruit these people, but you also need to make sure they understand this, right? This being the activities for the pediatrician. That's what this core component is really all about. And then finally, programmatic assessment, right? So I touched on this earlier. This is really about sort of many data points and as many data points as possible to try to figure out like, do I really understand what this learner is able to do and what they can progress to do next, and what they need to work on to continue to develop, right? And so this is an idea of having a very specific picture of someone's abilities and making intentional decisions about what they can do and sort of where they should go as they progress along the educational journey. Because what we're really trying to do is use competency-based education as an organizing framework, not only for training, but also for the certification process, right? So as you're going through and you're learning, and then you complete training and you have this profile of what you're able to do and what you really want to work on as you make the next phase in your career, we as a board are trying to figure out sort of what can the process look like to really continue to build on that, right? And smooth out some of the transitions that happen, right? Because the current system is very siloed, right? You do med school, you do residency, you move into practice, and each of those sort of function as a very separate thing, right? And so wherever we can, we are working to smooth that transition, particularly as you move from the training into practice space, right? Because this is really about the lifelong learning journey for all of us, which really should never end. And what that leads to, right, is this connection that hasn't always been there, right? So certification, what we do, and training programs historically have been these sort of two things that are related, but not necessarily very closely. CBME bring those things together, right? And there are parts of this that I think we are responsible for as a certifying organization. There are parts of this that programs are responsible for, but there's a big part in the middle that we really need to be working on together. And that's what all of this is really about. And so one of the questions that often comes up, you may be wondering, like, why are we talking about this, right? So isn't what we're doing really working just fine? And so I think the problem that we have now, right, is that data demonstrate if you use the EPA framework to decide on someone's readiness to practice, there's significant variation in ready to do the things at the conclusion of training. And I'm going to show you a little bit of data over the course of the next couple of slides to define that more clearly. But first, one of the reasons that's a problem is just simply lack of data, right? So if you think about programs, how assessment happens, you often have a rotation as a learner. And then at the end of the rotation, you have some assessments that get sent to your faculty. You may or may not get some of those back. And then if you think about a competency committee, when they meet every 6 months or so, sometimes there's like a single digit number of assessments over a 6-month period that the competency committee looks at to make a decision about, okay, is this person doing okay? And what's been described in the literature, and this is true in pediatrics and across multiple specialties, is this default pathway, right? So if I haven't heard anything negative, they must be doing fine, right? And so it's sort of like being dropped on a conveyor belt when you start training. You're moving along the conveyor belt, and unless somebody pulls the cord to say, like, we need to stop the line, there's a problem, then they must be doing fine. The good news is that all of you who are trainees in the room are in most circumstances going to do fine despite our system. But what we're really trying to do is make a system that allows everyone to reach their maximum potential, right? And move away from this default decision-making to a very intentional decision-making where I can say, okay, I have this body of data about this learner's progress. Here are the things they're doing. These are the things we need to work on. And then you can work on their development, right? So it's really about growth and continued growth over time. And if you apply this to other circumstances, right? Most people wouldn't be happy with this default standard, right? So I've had to fly 3 times in the last 3 days. Like, I'm moving around the country over the course of this week. And when you get on the airplane, like, do you want the pilot who, like, seems like they didn't have any problems, so they must be ready to fly the plane, or the pilot who has had a very intentional process to say, I can absolutely say with certainty, like, this person's ready to fly the plane from X to Y as you're moving along? Most of us will choose the latter. And I think our patients and our families deserve the same, right? And that's really what we're trying to move towards as we talk about this idea of more data for decision making. And so this slide's probably a little tough to read from the back of the room, but this is a study that we published back in 2020 that looks at readiness for practice using the EPA framework at the conclusion of general pediatrics training. So the EPAs are listed on the left side, so that's the left column. The far right column are the percentage of graduating residents who were deemed ready by their competency committee when they finished training. as you will see, none of those numbers are 100%, right? Ideally, that should just be a 100% column. Like, yes, this is an activity that's important. Yes, my graduate can do that. None of those numbers are 100%. The biggest gap was in behavioral mental health, which is probably not a surprise to most people in the room, given the way residency training is structured. And only about half of our learners were deemed ready for that activity when they finished training back in 2020 when this study was published. That's clearly not an individual problem, right? That's a system level problem that we have to wrestle with to say, what can we as a community do better to educate our learners in behavioral mental health so they're prepared to do the work that they're doing as pediatricians when they finish training. And there's been some work that's happened since then to really bolster behavioral mental health training in general pediatrics. There's also a new requirement from the ACGME. And so I think that there is progress as a community in addressing this, what is a systematic problem. But if you look at the new data, right, so we just redid this study in 63 programs, asking in a longitudinal way sort of progression of EPAs over time and readiness to practice. So these are the data from the table I just showed, right? So these are some of the high performing, least controversial EPAs, right? Most people would argue health screening, newborn care, acute common diagnoses, like these are the things a pediatrician needs to be able to do. The good news is that all of these are more than 90%, although like the idea that, 9% of graduates aren't ready for acute common diagnoses is, I would say, a concern. But if you look at the data that we just published earlier this month, the numbers have all gone down, right? And so that's probably a long and detailed discussion as to why trainees do not appear to be as ready at the time of graduation as they were before. There, I suspect, a multitude of contributing factors. But the punchline, right, is if you look at these activities, a concerning percentage of graduates aren't deemed ready by their CCC to do some of the things that we've defined as important for practice as pediatricians, right? And so when we talk about our why, right, our why for CBME, this is one of the problems that we're trying to solve, right? Is to make sure that as everybody comes through, everybody is ready to do the things that we've defined as a community are important for our patients. The subspecialty data are similar. This is a paper that's about to be published looking at graduating fellow readiness. And this just shows the 15 subspecialties that we primarily certify across the x-axis. The y-axis are the percentage of learners that aren't ready for either one or more than one activity at the conclusion of training. As you can see, there are a fair number of opportunities for improvement as we think about graduating fellow readiness for the activities that we've deemed as essential for practice. And so this is just taking the data from the previous slide and looking at one specific activity in a granular way to give you a snapshot of sort of where these people fall. So this is longitudinal data of about 1,500 or so graduating subspecialty fellows over the last 4 years, looking at the percentage that were deemed in a given category for the consultation EPA, right? So this is an activity that for all of the subspecialties is important for practice. And the levels across the bottom are supervision levels, right? So level 1 is observation only. So that means the faculty does the activity, the fellow is observing. The good news is at graduation, nobody fell into that category. Level 2 is direct supervision, right? So that means the faculty's in the room at all times during the consult. And there were 7 out of 1,500, right? So it's a small percentage, but a very real fraction of people who required direct supervision at the time of graduation for consultation, right? That's a concern. And then there's progressively less supervision as you move to the right of the slide. And the good news is about 2/3 of the people were ready for unsupervised practice. But then this category, right, the 2s, 3s, and 4s all needed some degree of supervision at the time of graduation. Now, most of the level 4s, I am going to hope, were probably ready for practice, right? So I think a lot of the level 4s are these like fellows that like need a little bit of extra support in the eyes of their CCC. But in an ideal scenario, right, those are folks that know their limits, are going to seek help when necessary. And a lot of faculty will say, well, that's normal, like graduating subspecialty fellow behavior. But there probably is a group in that level 4 category that we can't quantify based on the data that really do need supervision for the complicated patients, right, in a GME sense of the word, right? And so figuring out how to move all of these people to the right is really what we're trying to do. And then there's really little question in my mind that the people to the left, right, the 3s and the 2s, really needed more development, right? They need more development early in their training so they can be ready by the end. And this isn't about trying to decide like when someone's not ready so they can be excluded from graduation or certification or otherwise. It's really about identifying the needs of every individual as early as possible and then having them all fully developed, right? So that in the future state, when I'm talking about this slide and I show the data, everybody's in level 5 and then life is good, right? That's really where we're trying to go. And it's also important to remember as we talk about the levels for supervision and what's required for these activities, it's different from the milestone levels I showed earlier, right? So level 5 is not expertise, right? Level 5 is I'm ready to do this and I don't need a GME supervisor, right? And that's ready for practice independently out in the world, which is different from a milestone level 5, which is expertise, right? If you read the milestone level 5, it's like I don't meet very many of those, right? Because they're designed for someone who is like an expert, like a super expert. That's not what we're talking about here. We're really just talking about, are you ready to do the thing without someone supervising you out in the world? And so that's an important distinction as you think about how EPAs are assessed in comparison to the traditional approach to assessment using competencies and milestones. So how do you do this, right? So how do we really think about taking like these concepts and turning them into action, right? So the two things that you can really do as you think about the EPA framework and the activities is really building a framework so that you can address not only individual gaps, but curricular issues at the program level, right? So I touched on behavioral mental health as an example earlier. But as you think about the framework of EPAs and sort of what you do, either from the perspective of a learner, like these are the things that I'm doing and these are my gaps, or as a program, there are both individual and program level opportunities to address these. And the curricular piece of it can't be understated, right? Obviously, like I spend a lot of time in the assessment world thinking about assessment and are people ready? But at the program level, using the EPAs to frame curriculum so that the approach and the process are designed to meet the outcomes, right? So this comes back to the like earlier point about keeping the end in mind all the time. Is a really important part of the competency-based journey. And there's some work happening at the national level, right? There's some national curricula that have been created around behavioral mental health. There's one about addressing racism that programs can use as a resource. And those are designed using the EPA framework to make it easier for programs to say, okay, like this is something that my learners need to pay attention to, and here's some resources I'm going to provide them. And then at the local level, right, there are lots of opportunity for curricular evolution using the outcomes framework as a part of that. And so now switching back to assessment, you can really simplify the process using an EPA-based approach, right? So I touched on this a little bit earlier, right? So my guess is this question is very familiar to many people in the room, right? So like, what milestone level is this person for developing and carrying out management plans? And your answer to that question is probably highly variable depending on what context you're talking about and what the patient care scenario looks like. And what we're really trying to do, right? So thinking about this idea of flipping the script is asking the question, like, how much supervision does this training need to manage an infant with respiratory distress in the emergency room? My guess is every emergency room physician in the room or who's listening online can answer this question about every learner that they worked with in the last week or so, right? And so what you're really trying to do is take that question, translate it into a conversation with the learner about here is why I supervise you this much or that much, and here's what you need to do next time to move to the next level. Like that's really all we're trying to do. And so the good news is that from a faculty point of view, this is super intuitive and you do it every day, right? I was talking to Andy earlier. He's on clinical service. He abandoned his fellow out on the wards while he's here today listening to me, right? And that was a very conscious supervision decision that he made, right? He's like, I'm working with the third-year fellow. They're basically ready to go. So they are working independently in an unsupervised way, right? And that decision needs to be intentional. And I think what often happens is there may not be an intentionality always as a part of that process, right? There are probably some convenience contributors to some of those decisions. But thinking about it in a very specific way to say, how much supervision does this person need? And why did I make that decision, right? Is that because I'm a hoverer and I'm never going to let them be unsupervised? Or is it because they like really need me there? And if so, like, let's have a conversation about what the parts of that are, right? So there's a assessor and an assessee part of this, and the communication and the conversation is really the most important part, right? So how do you practically do this? One of the things we're doing is we just embarked on a pilot using the smartphone-based app for frontline assessment, right? So it's sort of like everything else in the world, there's an app for that these days. And so what we've done is we worked with this group, right? So it's the Society Improving Medical Professional Learning, to develop an app focused on assessment in general pediatrics residents. And it has a dashboard associated with it. And one of our key aims is equity and making sure that the system is equitable and building that in an intentional way on the front end. And for those of you that are familiar with work in other specialties, this is the same app that surgery uses in a broad way. So if you're a trainee in general surgery and you started anytime after July of 2023, they are all being assessed using this app, right? So we started a pilot using the same app and some of the same principles that they did, and just briefly walking through how it works, right? So if I'm a resident and I'm working with a preceptor and I'm seeing a patient with ADHD in primary care clinic, I clearly need a lot of direct supervision, right? Because I haven't done that in about 30 years. So that's really important. So my supervisor can initiate an assessment, or I can say like, oh, I'm going to push this to you and will you assess me? And then that assessment starts, right? And so you choose the behavioral mental health EPA. And one of the problems, which we touched on earlier, is that what you don't want is to ask this person to assess my ability to do all things behavioral mental health, right? That's a complicated question for them to answer, and that makes it a little bit difficult. So the first question narrows the scope, right? So the first question in the app is really about the diagnosis, right? So then you can immediately take the behavioral mental health umbrella, narrow it down to the ADHD clinic patient, and that makes the assessment by the faculty a much more straightforward process, right? So then there are a couple of questions. How complex was the patient? How much supervision did I need? And then you dictate your comments into the app. And then it immediately comes to me, right? I get the feedback and then it goes into the dashboard that in like later on, the CCC can review, right? And so the idea are these real-time micro assessments that are formative and entirely developmental. And then as you get more and more and more of those, a CCC, then all of a sudden, instead of having a single digit number of assessments every 6 months, you have a triple digit number of assessments that then you can review and say, oh, wow, like this person really is ready because they've done all these things. Oh, but by the way, like they've never seen a patient with suicide or self-harm. Like, so how do we adjust their curriculum to make sure that they're getting what they need? Entire process, start to finish. 3 minutes is probably a generous estimate, right? This really takes like 90 seconds. It's a quick process. It's really easy and can be built into the workday, right? Because one of the things we hear often, right, is about the burden of assessment and the time spent for assessment. Part of that is related to the fact that we have evolved into a system where assessment is almost an entirely administrative exercise, right? It feels like a burden of paperwork, and the meaning behind it and the value behind it, both for the faculty and for the learners, is often missing, right? And so what this does is sort of ideally, right, it shifts the script towards things that are more meaningful and things that are easier, right? And they go by faster. And so that is how the app works. Like these are just a couple of screenshots from the app. Like you choose your activity, you choose your complexity, you choose your level of supervision, you dictate in, and you're done, right? And so then what does that look like after you gather a body of data, right? So here's a snapshot of actual data from one of our pilot sites from 2 interns, right? So if you look at the intern on the left and the way this scale is oriented, right? So level 1s are at the bottom, right? So that means the supervisor's doing it all themselves. Ready for unsupervised practice is at the top, right? And so you can see the intern on the left, all of their assessments, right? They're like pretty close to being ready, right? This is somebody who is trucking it along. This activity is going fine, and there really aren't any concerns. If you look at the intern on the right, they don't have any that are ready for unsupervised, and most of theirs are much further down, right? And if you take these data and you pair them with the narrative comments, like the narrative comments are very telling, right? The person on the left is clearly a superstar, right? That person is really doing a fantastic job. The person on the right has some opportunities and some things they need to work on in this activity, right? And the goal here is to really take each of these individuals and say, for this person who's high performing, what can I do to take you to the next level and make you an even high performer? And take the person on the right and say, okay, what do we need to do to get you to the bar that we're trying to set, right? This isn't about sort of trying to say like, oh, this person's fine, we're going to leave them alone. Like it's really about taking every one of these folks and moving them up on the scale each time. And so that's what having more data allows you to do, is it allows you to identify what an individual's needs are and how you can help them develop as a trainee and then eventually as a pediatrician. The more common scenario in the current state looks like this, right? So maybe this person's doing fine, maybe they're not doing fine. And if you go back to the discussion from earlier, like I haven't heard otherwise, so things must be okay, right? And so we're trying to move from this world to the world on the previous slide, right? And that's really what we're trying to do as we think about programmatic assessment and what we're doing. The work with the pilot has gone well so far. We've had 15 sites that have been involved for a number of months now. They sort of onboarded at their programs in phases. That number now is like in the 6,000 range of assessments, which continues to go up every day. The forms are super easy. They're all being used. And the qualitative feedback about the app has been quite positive, right? It's pretty rare to ask folks about an assessment system and get anything positive. But the responses have been quite good about this, right? And it hasn't been all rainbows and unicorns, right? There's some challenges here. particularly as you think about this idea of being assessed regularly. Like some of the learners in the room are probably like, oh my gosh, like I am not ready for this. Because oftentimes we don't have a learning environment that's conducive to these like vulnerable conversations about what someone's ready to do, what they're not ready to do, and how we can help them develop, because we have this, there's a performative aspect to care, right? Because the residents feel like they need to be putting on a show so that their faculty then see they're doing a good job. And then there's this vicious cycle, right? And no one really acknowledges what they know and what they don't know. And then it sort of stagnates development, right? And what we're really trying to do is create an environment where those conversations can happen and the focus is on growth. And there's a responsibility there for both the learners and particularly the faculty, right, to be willing to do that. And what we've seen, right, is some of that anxiety that that both trainees and faculty have expressed early. The quote from one of our program directors, right, is that the pre-stress was much more than the actual stress of implementation. So they were really worried about some of these things in advance, but once they started and once they got it going, they realized that those things didn't come to fruition nearly as often as they thought they would, which is reassuring and exciting to see. And so sort of moving back to this previous slide I showed earlier as we finish up, we're really trying to make this process meaningful, right? So I touched on this idea of like assessment as administrative exercise. Like if we can move towards a world where an assessment is a part of the educational process and it's really focused on growth and development, that's what we're trying to do. Right. And so this is often described as like pixels on an image, right? So if we looked at this long enough, like I could probably take some guesses in the room of what this is actually a picture of. But if you take and you increase the numbers of pixels in the image, right, translate this into data points, right? So you have increased data points about a learner, you get increasing clarity of what the image might look like, right? And so if you add enough pixels to the image, the picture is really sharp, right? And so this is what the person looks like. This is what they're able to do. And this is how we can help them develop, right? And so that's the idea of programmatic assessment, lots of data, lots of decisions that can be made in a very intentional way, right? And so where are we going next? What can you do locally? So one of the things we've done as a board is making sure that we align our assessments, right? So I touched on earlier, we do lots of assessments. Most of those at this juncture are multiple choice, and making sure that those are aligned with the outcomes in question, right? So that the EPAs are used as a starting point for development of our blueprints and our content outlines, and then our questions sort of roll up to those, right? So we're trying to move towards a world where increasingly the things that you are assessed on by us are the things that are important for practice, right? And so that's a priority for us as we advance the CBME journey. We're going to be using EPAs and the principles of CBME as a part of the certification process because we feel like it's an important priority for us with our obligation to the public to ensure that as graduates are moving into the world of certification, they're able to do the things that the community feels are the important activities for pediatricians. And then we really see the EPAs as a framework for lifelong learning, right? So I touched on this idea earlier, the training process, and when you complete your program, whether it's Gen Peds or fellowship or wherever you finish your training, is really just the beginning of the learning process, right? And so figuring out how we can use this framework for lifelong learning is an important priority for the future. So what can you do? This QR code takes you to the EPAs on the ABP website. The first thing to do is just read through them, right? And so look at them and say like, oh yeah, like this actually does apply to what I do as a pediatrician or a pediatric subspecialist. And then think about how you might use them in your training program, right? For the educators in the room, or for those of you that are faculty that are taking care of patients with learners, right? Whether you realize it or not, you're an educator. Thinking about these activities and sort of framing the care that you provide, the supervision that you're giving the learners through the lens of what it is they're trying to accomplish is really important. And the easy thing, right, is when you take care of a patient, think about how much supervision either you were required as a learner or that you provided to a learner and say, like, why did I make that decision today? Right. And so then you can have a conversation about, okay, like, here's how much I supervised you, and here were the decisions that I made to get there. Let's talk about your experience there and how we can move to the next level, right? And that's a relatively straightforward conversation. And if those kinds of things start happening, that really sort of moves the world towards a more competency-based approach to thinking about both education and assessment. This is one of my favorite quotes. A lot of this is like super overwhelming and it feels like a lot. But this is one of those things that small steps after some period of time really takes you a long way, right? So if you can figure out like, what is it can I do today that moves me like a little bit down the path, and you keep doing that regularly, you realize like, oh, wow, like I've gone a long way after time has gone by. So with that, I'll stop and we should have a few minutes for questions. Thanks.